Thank you, everyone. I'd like to announce our student table today. We do have, from National, a sponsorship of a student table. And I'd like the students to stand and thank you for coming from Centennial College. Thank you so much. Yeah. Thank you. Good afternoon, ladies and gentlemen, from One King West Hotel in downtown Toronto. Welcome to the Empire Club of Canada. For those of you just joining us through our webcast or podcast, welcome to the meeting. Today's topic, federal changes in the pharmaceutical landscape, how a national Pharmacare plan and regulatory reform impacts Ontario patients, the life sciences industry, and the health systems. Canadians are eagerly awaiting policy decisions by the federal government. As a result of the ongoing work of Prime Minister Trudeau's Advisory Council on the implementation of National Pharmacare, and this council reports to the Minister of Health, is tasked with leading a national dialogue on how to implement affordable national pharmacares for Canadians and their families, employers, and governments. Dr. Hoskins, chair of the council, has been on the road over the past year conducting consultations with the public and the industry. His view is that ensuring access to prescribed medications is vital from both a health, equity, and health outcomes perspective. He said, quote, "Too many Canadians are unable to maintain or achieve a healthy life because they cannot afford needed prescription drugs," unquote. I don't think any Canadians would object to the overarching objectives of the federal government, but today we are here for a conversation amongst our experts that will focus on whether these goals are achievable and what the impacts are. To add a layer of complexity to the policymaking landscape, there is also an ongoing federal review dealing with the price increases in pharmaceuticals led by the Patent Medicine Prices Review Board. We are all conscious of the challenges before policymakers in implementing reform in response to the pace of health care innovation and Canada's growing and aging population. And the general idea that 20% of Canadians are unable to fill their prescriptions because they cannot afford it. There's no shortage of discussion and opinion on this. And these discussions will no doubt accelerate in advance of the 2019 general federal election. The Empire Club of Canada has been at the forefront of conversations on healthcare throughout Canadian history, including the 1950s when Canadians were considering whether they should have a public healthcare system at all. Of the challenges on implementing a public system, the president of the Canadian Medical Association said in a 1956 speech, quote, "For many of us, perhaps all of us, this is a time of reassessment and decision, a realistic self-appraisal and optimistic planning. But our plans, if they are to reach fruition, must be built upon sound foundations. It is out of yesterdays that we gather the ingredients of our future planning. It is out of our tomorrows that we anticipate, hopefully, the course which we desire to follow," unquote. This sentiment is just as relevant in 2018, and that's why the Empire Club of Canada has invited this panel here today to set a sound foundation for the upcoming national discussion on Pharmacare. Like all great decisions, in this end, it is Canadians that need to make up their mind. So prior to launching into the panel discussion today, we will kickstart today's conversation with a polling presentation from Nik Nanos that was commissioned by National Public Relations. Mr. Nanos has recently been in the field conducting research around Canadian impressions of the performance of specific elements of a national pharmacare program. Nik Nanos leads Nanos Research, one of Canada's most distinguished research companies. He is the pollster for CTV News, Canada's largest private broadcaster, the Globe and Mail, Canada's national newspaper, and Bloomberg News in Canada. His book, The Age of Voter Rage, The Tyranny of Small Numbers, explores how the marginalized and the margins are rewiring democracy throughout populist-style politics, small swings in voter sentiment, and computational propaganda. I'd like you to define computational propaganda when you come to the stage. He is a global fellow at the Woodrow Wilson International Center for Scholars in Washington, D.C., and a research associate professor at SUNY University at Buffalo. Please welcome to the podium the leader of one of Canada's most distinguished research companies, put your hands together for pollster, Chief Data Scientist and founder of Nanos Research, Nik Nanos. Thank you.
Thanks for that introduction. So, big surprise, invite me to a lunch, and I have some data and polling to share with you. And actually, what I'd like to do, and I think this is actually quite important, many times on a lot of public policy issues, you have what I'll say, people in the know, people that are experts, people that are stakeholders. I guess it's kind of like the talk amongst themselves on issues and what they think should happen. And my role is actually to bring the voice of average Canadians to the table. Because the reality is that Canadians have an interest in healthcare. They are key, why don't we just say the key stakeholder. And it's important for us to understand how they feel about a lot of these issues. And so I will be, good news, snappy. I'm going to basically do two things. I'm going to talk about the top issue of concern because it's actually very important to have context in terms of what we're talking about. And then I'm going to unpack the polling data related to a national universal drug ban. So I'm not going to read this. This is the methodology. The poll is good, as I would say. Good. You can rely on it. Take it to the bank. You know, it's interesting. Every week we ask Canadians what the top national unprompted issue of concern, and they can actually say whatever they want. And usually this, this particular question surprises many people because usually they expect what's in the news to be the top national issue of concern. So if the Prime Minister goes on a trip to some South Asian country and with his family, they expect that to be the top national issue of concern. Or if there's talk about a gun registry, they expect that to be the top national issue of concern. Or if there's some big issue that blows up in question period in the House of Commons, they expect that. And it's interesting that the reality is that we should delineate between what Canadians take an interest in and what is important. And day in, day out, when we ask Canadians what is important, you can see these top issues actually consistently come to mind. Can my mother get her hip replaced? Can I access health care? Do I have a job? Will my son or daughter have a job when they graduate from college or university? And what are we doing on the environment? So you have to think of these issues as fundamental issues that are actually critically important to Canadians. And we should delineate that between the other issue. I don't like to call it the clown show or the goat rodeo, although I just have. But these other kind of secondary issues that might seem very politically sexy, that the media love to cover, but realistically are more entertainment. They fall into the category of entertainment as opposed to key drivers. And that's why when we do research on an issue like healthcare, I would hazard to say that we have people's attention. Because whether you are in the healthcare system, whether you are making healthcare decisions for other people, or whether you're healthy and expect at some time to need to access healthcare, you have an interest in this issue. So I just want to kind of put that on the table. So, what we did quite simply is we tested, this is a bit of a report card. It's kind of like very good, good, average, poor, very poor. We actually tested the concept of a new national universal drug care program managed by the Government of Canada, and asked Canadians to say, how do you think the Government of Canada would do if it was responsible for managing a new national universal drug program? And not to get overly technical, but there's not a lot of green when you look at this. And actually, when you look at the very good score is actually quite soft. Their best very good score would be 15%. And when I say they, I don't mean the Liberals. I don't mean Justin Trudeau. I just mean the concept of the Government of Canada. So this is nonpartisan. And you can see, so a high of very good at 15% in terms of access. You can see that very good score going down to 8%. But the key takeaway here is that a significant proportion either say average or actually would score the federal government as poor or very poor, especially when it comes to whether the federal government can run a lean program that doesn't create unnecessary paperwork, whether the government might interfere in the decisions and recommendations of physicians, and also related to what I'll say, tax dollars and managing costs. So what I want to put on the table is the concept of we should delineate between the words National Universal Drug Plan, because, hey, let's face it, who would be against those words? It sounds excellent. And kind of unpack that in terms of prompting Canadians on, when we think of these different elements, if this were an objective for us, how you feel, and actually it's quite clear that it's not what I'll say a big green light on these. And just to kind of unpack these a little more, you can see some variations in views. You know, not surprisingly, if you're in the prairies, you're probably most likely to have a very dim view of the government's ability to manage prescription costs under a new national drug program. The other thing is that the less experience that you have, the more positive views that you have of the system. You can see if you're under 35 years of age, you're more likely to score very good or good compared to if you're over 55 years of age. And you can see also when it comes to the ability to spend tax dollars well and scoring the federal government on that in relation to a new national universal drug program, that the overall number is actually quite weak. If you're in Quebec, you're probably more likely to say that you do a very good job. And if you're in the West, whether it be in the prairies or British Columbia, you're least likely to kind of score the federal government as very good or good in terms of spending. And then on the lean, actually the one thing that is lean is the very good score in terms of this at only 8%. So less than 1 out of every 10 Canadians would score the federal government as very good in terms of the perception of Canadians, in terms of a system that would not create unnecessary paperwork, and that would be lean. And this is quite interesting, because this has to do with government choosing physician and physician choice, and kind of what I'll say the trade-offs on that front. And you know, not surprisingly, you can see that the very poor scores are actually quite strong, and that another 31% actually score the government as average on this, but still not a big kind of vote of confidence in terms of where this might go. On the access front, access received the strongest comparative. It wasn't super strong, but it was the strongest comparative choice. And I think a lot of this has to do with kind of what I'll say how this is framed. When you say a national universal drug program, I think without knowing anything about the details, you would expect that it would realistically or potentially do a reasonable job in terms of access. But still, you know, the key takeaway on all of these is that there's no majority on the positive side of the ledger in terms of confidence for any of these measures. You could say that it's either mixed or ambivalent, but it's not a big, as we would say statistically, a yee-haw in terms of the federal government on this front. So, to close, think of healthcare and jobs as kind of the key factors that Canadians will look to in the next federal government and next federal election. And, you know, I would hazard to say that I'd always kind of say this is what people want to hear about. It's not necessarily, and I'd like to also say that many times governments don't necessarily talk about what voters want to talk about. Governments usually want to talk about what they want to talk about. But what the polling does show is that there's significant appetite for engaging on healthcare issues and jobs and also the environment. Confidence in a national Pharmacare program that's run by the federal government is generally weak, which means that for the federal government to engage on this file, they're going to have some explanations on how they would do a good job. that it's more than just what I'll say a throwaway tagline to say, let's have a national pharmacare program. They need to put some meat on the bones to explain Canadians in order to try to drive confidence in terms of how this would work and how Canadians benefit. And the best comparative score is access, and the worst comparative score has to do with paperwork and not being lean. So with that, I thank you for your attention, and we will, I believe, transition to the juicy part, which is the panel. So thank you very much.
Thanks, Nick. That was fantastic. So right into the panel. Our first panelist is a Monk Senior Fellow for Fiscal Policy at the Macdonald-Laurier Institute. He is also an Associate Fellow at the R. Street Institute and a Fellow at the University of Toronto's School of Public Policy and Governance. Lots of fellows going on. He previously served in different roles for the federal government, including a Senior Economic Advisor to the Prime Minister. He has written extensively about federal policy issues, including tax and government spending, retirement income security, social mobility, and economic competitiveness. He has an MA in history and has studied economics as a PhD candidate at Queen's University. Please welcome Sean Spear. Our next panelist is President and CEO of the Canadian Organization for Rare Disorders and Chair of the Consumer Advocate Network. She was also President and CEO of the Institute for Optimizing Health Outcomes and Chair of the Canadian Heart Patient Network. Internationally, she is chair of the Rare Disease International, which is the Global Alliance of Rare Disease Patient Organizations. Durhan has a PhD in psychology from McGill University and was professor at the University of Windsor from 1984 to 1999. Please welcome the President and CEO of the Canadian Organization for Rare Disorders, Durhan Wong Ryagar. Thank you. And today's moderator is a former journalist. She worked for more than 30 years as a print and broadcast journalist, spending the majority of her career as a political reporter and columnist on Parliament Hill at Queen's Park. For 6 years, she was co-host of CTV's Question Period, an hour-long political affairs program on CTV's main network. She spent 14 years at the Globe and Mail, 10 of which as a columnist and senior reporter in the Globe's Ottawa bureau. Jane knows all the players in today's media. Since joining National, she has been integral on key files, including helping government spokespeople, senior executives, and CEOs prepare for dealing with the media, both in proactive and reactive situations in the crisis. Please welcome today's moderator, Vice President, Public Affairs, National Public Relations. Thank you.
Thanks very much, Kent. Really appreciate it. Appreciate everybody coming today. And we're going to have a yee-haw panel that Nick was talking about. So let's get right into it. So to you first, Sean, I want you to make a bold prediction. And I want you to tell us what's going to happen in that budget that the Trudeau government's going to be delivering in this spring. It's a pre-election budget. Are we going to see a Pharmacare program?
Well, first of all, let me thank the Empire Club for hosting me today and say it's a bit intimidating to be talking about this issue to this room. I see a lot of people who've been writing and thinking and active in the healthcare field for a long time. And so I can't help but feel a bit presumptuous making bold predictions and telling you, this informed audience, what's going to happen. But if I was a betting man, and the reason I have all of those titles is because I don't have a lot. I have to take all these jobs to earn income, so I don't have a lot of money to bet. But if I did have money to make a bet, I would say no. I think Mr. Morneau, many in the room know that there is a tension, I think, within the governing caucus about how to tackle this issue. Members of the House Committee endorsed, of course, the idea of a national single-payer Pharmacare model. I think as this government approaches its final budget, its pre-election budget, and thinks about not just its fiscal framework as a government, but also its electoral strategy, I think in the end it will ultimately make the judgment that, well, it needs to make progress on this issue. It will do that in a more targeted, less ambitious way than members of the House Committee recommended just months ago.
So it's because of cost then? They're just going to be a little cautious? You think that they're vulnerable in that area?
I think in part because of cost,
Yeah.
and in part because of the ongoing weakness of the New Democrats. I think this government will feel less political or electoral pressure to make progress on issues of interest to progressive voters. And for that reason, I think, well, we'll see some action on this front, and I hope we can talk a bit about what a targeted approach might look like. I think in the end, Mr. Morneau will win the internal debate about how to proceed on this front.
Oh, so that's what's driving it. You have some inside information
No,
about
no,
what Morneau's up to, that he's totally against
I
something
assure you,
like this?
Mr. Morneau isn't asking me for my advice.
Okay, well, let's just move on to Durhan then, because you're the patient representative on this panel, and you're also on the Committee for the Federal Drug Pricing Reform. And so we wanted to ask you about how are Canadians to be reassured, or should they be reassured, that the federal government knows what it's doing with its decision to move forward with pricing reforms. And we saw that story on Saturday reported in the CBC about what your panel is doing.
So maybe, first of all, thank you very much for the opportunity to be here. We certainly have been talking a lot about national Pharmacare and certainly about the Patent Medicines Price Review Board and the proposed regulatory changes. But this is a great audience because I think it's a much broader policy and financial audience than we normally have in this course. And actually just listening to Sean, I feel like I just ought to leave. That's a very, very, it's either a really depressing kind of a thought, because we're all working very hard to try to improve the access, and whether it's, quote, a single national Pharmacare universal health coverage, I mean, we really do feel strongly that there needs to be additional funding that comes in, and quite frankly, the federal government, I think, is putting this forth, and we would love to see something happen out of it. So I think that's a very a depressing kind of a thought. On the other hand, maybe it's just throwing the gauntlet to us that the rest of us should really think about how we're going to make this happen and prove you wrong. So that's that's kind of my thought here, and I'm hoping that the other patient advocates who are in this room and the others that are involved will see this as an opportunity maybe to really see how we can push this forward. In terms of the Patent Medicines Price Review Board and sitting on the steering committee, and as you say, Jane, there was a very strange article, quite frankly, from my perspective in the CBC that really talked to some of the discussions that supposedly are taking place, but also very sadly, seemingly providing the views of what the leadership at the PMPRB thinks about what is taking place here, and also, quite frankly, chastising not only the industry, but really the patient groups for some reason not wanting to make sure that prices are going to be affordable, which I think is a huge misrepresentation of what we're all about and how we're doing that. So if the question is, do we think the federal government knows what it's doing? I think we have been very strong in terms of both our submissions to the first consultations, certainly sitting at the table, and really what we've been saying is that the pathway that you've put forth is actually not only not evidence-based, it is ill-conceived, it actually has huge risks and potential harms. For me, it's not talking about what the industry is, except for the fact that we need the industry to continue to bring in new therapies to Canada. So we're very concerned about what's in there, not only because it will provide that risk, and quite frankly, we would love as patients to see a very transparent system. Let's put everybody's prices out there. Let's not make it like shopping for a car in a used car lot, where nobody knows what the price is. You're negotiating with some wizard behind the closed door while you're trying to guess what the right price is and hoping you didn't get screwed, even though you're doing your very best there. But that's how we feel, right? But that's not the way the world works. And if Canada says we're going to go a totally different path that's going to make it really challenging for companies to want to invest in Canada and to make Canada a good place to do clinical trials and to bring in innovative therapies, then we lose. And we've been pleading for an alternative pathway.
And talk about what we lose. What are the consequences if these reforms do go through?
Okay, there's two basic parts of the reform, right? One is to suggest that we need to change the reference basket of countries that we're going to compare our pricing to, that we've been including too many countries that actually are much higher in terms of the OECD average countries. We don't have any problems with that. I think looking at a median pricing and looking at how we can adjust that better, but quite frankly, we have always said in terms of Canada, how will it come if it's that companies are coming to Canada as they're doing to all of the other 30-some countries that are in there, we end up with the worst pricing. Are we just lousy negotiators? We have no idea what we're doing. So that to me is one question. But the second question is, They're introducing then a different formula for how they want to set what would be the ceiling price. So as a price control country, we have a ceiling price, and we know that nobody pays it any more than you pay the sticker price in a car lot, unless you just don't really care. And so we do negotiate down, right? But if we end up with a ceiling price that is going to be what is mostly our negotiated price, and that's the price we stick out there, and we are also a reference country for many other countries, nobody's going to come to us. What they'll basically do is say, okay, fine, let us go to other countries where we can actually get an adjusted price.
So you're saying that Canadians then will lose out on drugs that are coming, those drugs won't be available to us?
Well, they may not be available. What we won't be available, Jane, is we will not get access to drugs early, which means we don't get clinical trials. Because quite frankly, the way it works right now is that if you bring in a drug and you have it in a clinical trial, after the clinical trial is done, there's a period of time before it goes to market. Usually what companies are doing, out of a very strong ethical principle, is you keep the patients on those drugs until it actually gets reimbursed, right? But if you're looking at Canada, and number one, we have very low prices, so it's going to be challenging to want to bring it in early, we're not going to bring the clinical trials. Or if we do, and we have an even longer negotiation period, which is already 2 to 4 years sometimes, me as a company, really, I'm going to bring in a drug, put the patients on clinical trials. If the drug works, now we start to bring it to market, I'm going to carry my patient for 2 to 4 years while we're trying to, I don't think so. Yeah. And we can't ask that. We put ourselves at a huge disadvantage.
Okay, Sean, you want to jump in?
Yeah. I agree with much of what's been said, and I think what underpins all of it is that policymakers on the PMPRB reforms in particular need to think more carefully about the trade-offs that are implicit in the draft regulations. I think the broader question of Pharmacare also involves some trade-offs that I think policymakers and the public need to be cognizant of. Presently, there are approximately 70% of Canadians, about 23 million people who are getting their insurance through their employer, and by and large are satisfied with the model, both in terms of price and access. We have another 10 million Canadians who are receiving drug support through various public plans. But there is a cohort that presently doesn't have insurance. And so I think it is a legitimate question for policymakers to think about, how do we address this gap? We're talking about approximately 3.5 million people, of which people in the room may be surprised to know about 2.8 million, 80% are self-employed. And so I think there is room for policymakers to think about, how do we conceive of a policy intervention that targets this legitimate cohort? But the reason why I think presently this discussion isn't involving the kind of reconciliation of trade-offs is remember, we have 70% of people, 23 million people who are generally satisfied with the status quo, with the current regime we have. We have 3.5 million people who need a better model. And it seems to me trading off the regime for the people who are being well served to deal with a targeted yet relatively small problem would be a big policy mistake, and I think ultimately a political one if Mr. Morneau is listening.
Okay, well Nik wants to get in here too. Jump in there, Nik.
So you have to think of it this way. I think one of the challenges, I might say something that's unpopular, is that this whole policy discussion has been distilled to slogans by politicians and played on people's fears. Because by saying that we need a universal pharmacare program implies that that there's a significant proportion of Canadians that do not have access. So it plays on fear. And I think one of the things that needs to be done is actually to educate Canadians on our system and how it works. And when I look at these particular numbers, and these numbers are not good, why are they like that? You know why? Because in the past, governments, if you remember Romano and Kirby, created such high expectations that were not delivered on. And the one thing that Canadians have probably learned in this process, it's kind of like the Wizard of Oz, right? They want the outcome, they're actually not interested in what happens behind the curtain. You know what that's all Canadians care about? That if I or a loved one needs a medicine, they want the newest, best medicine for their loved one. No?
Yeah.
You don't think so?
Okay.
But no, I'm just saying, just from the research that we've done, they want the best and newest medicine to kind of help their loved one. and they want it as fast as possible.
Well, they're not going to get it if these reforms go
Well,
through, right?
I think that's a little bit of a way in which you ask the question, quite frankly. You know that's supposed to.
Yeah,
right?
no, but-
I mean, because if the question is, if there
No,
were...
I don't think you need to ask a question to ask people to say if you want,
We live with patients all the time, right?
and they say they don't want the
No,
newest
no.
and
What
best medicine.
patients say is, I want the medicine that's best for me. And if I'm on an older medicine that actually works really
Yes,
well, and
true.
it's been around for a long time, and I know what all the side effects are, and it's easy to manage, and it's cheap, and
Oh,
so
we're
that-
saying the same thing.
Yeah,
Yes.
I mean, I'm happy with it, right?
The best.
What the problem is that in many cases, right, and certainly for many of our patients with rare diseases, where only 5% of patients actually have medicines, or you're talking about life-threatening conditions, cancer, you're talking about heart disease, or you're talking about patients who are not well served on the medicines, even if we've got lots of medicines. I'm looking at arthritis. I mean, yeah, sure, a lot of patients do well, but in fact, there are some patients who are not doing so well. So for those patients, right, and this is where we come back to, and I think it's all what we're saying, is that there is a cohort that's well served. But the problem is that for that cohort that's not well served, who does need that best medicines that come in the innovative medicines, the one that's just being developed, we want Canadians to be able to get access to that.
Okay, so what's the answer then? You know, you guys have you know, brought up all the problems and the challenges. So give us some answers. Give us the solution, and maybe Morneau's listening.
Yeah, well, not just Morneau. I think everyone in the room, particularly those who are raising legitimate concerns with the prospect of a single-payer Pharmacare model. I think it's a strategic mistake to simply point out its errors or its flaws and neglect the 3.5 million Canadians who are being poorly served by the status quo. I think there's an onus on critics of national Pharmacare to put forward a targeted solution to speak to the concerns of this cohort, because it's going to grow. As I said earlier, 2.8 million of that 3.5 million who are currently underserved are self-employed, and because of economic trends, I think that share of the population is only going to grow. And so we need to make sure we have a regime in place that is providing access to insurance for that cohort. And it's not going to be through a single-payer model. Okay. But I think there are some sensible steps that policymakers at the federal level can take to have a strategic, targeted approach as opposed to a bazooka. And what I've been advancing in my own writing and my own commentary is a redesign of the medical expense tax credit. People in the room will be familiar with the METC. It's presently non-refundable. The caps are actually quite low. If I was advising Mr. Morneau or any federal politician, it would involve a major redesign of the METC, make it refundable, expand the caps, make it easier for people like me, incidentally, who doesn't have employer-provided insurance to be able to go out and acquire private coverage. I think that's not only the right political approach, I think it's the right substantive approach. And I think there is an onus on critics of Pharmacare to be putting forward positive, constructive alternatives, because otherwise, I fear we're going to end up with the worst-case scenario.
Okay, Durhan, what's your
So
solution?
let me speak to the cohort that I think everybody is interested in, and that those are the ones that are underserved, or the ones that aren't going to be able to get access, which includes, you know, many of us are small employers, right? So for the rare diseases, we actually have put forth a proposal for a single system. And it could be partly funded by private, could be partly funded by public, but it would require, I think, some substantial investment by the federal government in order to make it work. And it would be, it actually was first initiated under the Expensive Drugs for Rare Diseases Working Group, which Dr. Hoskins put in place. They have just this past couple weeks put out a supplemental process, a plan for how that could be achieved. And the goal of it is, what I would hope everybody would agree with, is based on you pay for outcomes. So patients are enrolled in the plan based on, in many cases, very tenuous evidence, because these are rare disease drugs, small patient populations, or it could be new precision medicines. If the patients do well, they are maintained on the drugs, the government picks it up. If they're not doing well, they're taken off the medicines. That makes good sense. Or they are put back on a different medicine. It's a risk-sharing program, which means we ask the companies to step up and actually help partially fund, or maybe totally fund that first portion while the patients are actually trying it out. It's a reward for getting early access and not necessarily having to do clinical trials. But because they're in a monitor program, we collect evidence, what we like to now call real-world evidence, on an ongoing basis to demonstrate whether it works. So instead of having big clinical trials up front before patients get access, these are patients that have severe conditions, unmet conditions, you expand it this way, and you put in the same kind of concerns. It does mean that the government has to shift revenues in order to put some of that revenues up front. These are expensive therapies. It also means, and I've been involved in the US right now, for instance, in a whole project called New Digs, which is looking at innovative financing models. It's not a question of funding, it's a question of financing. How do you invest up front in order to be able to reap the rewards and shifting that? And that might require a financial solution that, quite frankly, we hope that the feds could help put together in order to make this happen. So there is a solution. It's for a really well-defined population. And quite frankly, it's about, at this point, less than 5% of what we're talking about in the total drug budget. It's totally doable.
Okay, so Duran and Sean came up with some great solutions. Nick, based on
I can't speak to the policy of this, but
no, but you can speak to your
politics?
you can speak to the politics, and you can speak to your numbers and tell us if you think Sean's right that they're not going to go for a national Pharmacare program in this upcoming.
Well, that
election or
presupposes that politicians make smart decisions.
Well, yeah, okay, all right.
Sorry, that's a different panel at the Empire Club. I think if they're just looking at the numbers from a public opinion perspective, I think the two words, be cautious. You should not think that this is a complete slam dunk politically, that it's a complicated issue. And you know what? Like I said before, Canadians are not public policy experts, but they know that the health system is complicated and complex. They don't know how it works. And you know, whenever governments propose change, the default now, I think, is cynicism. Yes. That they're not actually, you know, you make all these promises, and there will be unintended kind of outcomes that were not clearly put on the table or understood. So, you know, I would say be cautious. The other thing that, you know, speaking to Sean's comment, should Minister Monod have this in the budget or not? I think a lot of this has to do with dollars and cents and the fiscal position of the government. And what it might be in an environment where people are worried about their jobs. We've just seen layoffs in Oshawa. We'll see more layoffs. They're concerned about our relationship with the United States. And you know, people will be looking, you know, our polling on things like the deficit suggests that Canadians generally are okay with the deficit every once in a while, but it is not carte blanche to run a deficit every single year.
And especially when you said that the deficit was only going to be this big.
They gotta, you know, if the Liberals want to have a chance to win the election, you know what, they're ahead, but it's fragile. Their lead is fragile. They have to come back to Canadians and to make sure that from a fiscal perspective and economic perspective that Canadians feel a little more comfortable. So I'm not sure if there's going to be the room to do what some people would want done.
Okay, well, thank you very much. So I've had my chance to ask our panelists some questions, and now you have an opportunity to ask a few questions. And we've got some mics here, and so stand up and ask away. You've got an opportunity to speak to these experts. Thank you.
Hey, Sean, great panel. I'm a little surprised that the focus of the panel is on the federal government. Because, you know, if the federal government gets it right, well, it's the federal government, so they won't get it right. But if the federal government gets it wrong, then they'll screw it up for the entire country. And where we should be talking about what the provinces are doing. The provinces actually run healthcare. The provinces are starting to put in place Pharmacare programs. There's different programs across the country. And I think that's the proper way to do it. The model might be what we did for carbon pricing, or trying to do for carbon pricing, where you let provinces put in regimes and maybe at the end put an overarching thing. So I'd just like to hear the panel speak about why in the world you want the federal government to do anything at all. Why not let the provinces do this? Because they're more likely to get it right.
Who wants to start with answering that?
Well, I will go back to the narrow population that we're talking about right now, right? So the proposal that has been put forth is put forth by the provinces and territories. So it's very much owned by them as the recognition. We have had some great models in terms of how this kind of what we call a managed access program works, the risk sharing program works. And it starts off usually with a 1/3, 1/3, 1/3. 1/3 federal government, 1/3 the provinces, and 1/3 in terms of the companies that are doing it. So it gives us an opportunity to have a bolus of funds to actually implement it. So you're right, we're not asking the federal government to underwrite a program, but we do think that there needs to be some incentives. And some of that incentives covers off the fact that patient populations are unevenly dispersed. So for any particular kinds of therapy, you may have patients that may be more likely to be in the Atlantic, et cetera, et cetera. So in order to make that work, but we think as an initial investment, this would be a way of getting it started.
Okay. Is there anybody else who wants to?
Yeah, actually,
Nik?
if I could add on that, if you look at the polling numbers, we tested on the Government of Canada, and you'd probably look at that and say, perhaps you should be engaging provinces if you actually want people to have a little more confidence in this, and that a process that is too focused on the federal government is incomplete, and people are more likely to be cynical about it. So, so engaging the provinces and having the provinces as real equal partners on this, as the people that are primarily responsible for delivering healthcare, I think is critical in terms of making people feel a little more comfortable. But it doesn't mean that they'll be comfortable anyways, but I think they'll be a little more comfortable if there are provinces that can come to some kind of
The only thing I would add is not only do I think that Ken is substantively correct, as always, I also think the elephant in the room of a national pharmacare proposal is the province of Quebec, which I think was under-considered in the Health Committee's report, and particularly with the change in government in Quebec City, the idea that the federal government could simply announce a new national pharmacare in its budget and without opposition from Quebec strikes me as foolhardy.
Okay. All right, we've got a question over here. Yes?
Thanks very much for the panel. My question is, first of all, I'd have to say that I think that we certainly need to engage the provinces, but I'd like us to keep one thing in mind, and that is that the federal transfer payments for health have been going down profoundly year over year. So I think if they even would, reinstate previous funding, we'd have some money in the budget for this. And I'd like to make a proposal for what could be done on the Be Cautious model. Why couldn't we just ensure that the federal government provides to the provinces enough funding that every person in their province would have access to the minimum public plan, notwithstanding their income or their geography? Surely that would be a really profoundly good first step, and if it's administered by the provinces, it also deals, Nik, with your issue about not only being cautious, but also lean and let's use the existing resources instead of creating a whole new bureaucracy. What do you think about that idea?
I mean, I think what Louise is saying is kind of the intuitive right answer, because national pharmacare could look a whole lot like national health care, right? We have national health care, we have consistent standards, we have not necessarily absolutely the same, but we do have some basic principles and foundations. And I kind of think this is where Dr. Hoskins is kind of going anyway. I mean, we need to look hard at Quebec. Why is it that Quebec patients are so much happier and so much more likely to trust the government? Because they actually do have a provincial pharmacare program. Everybody has some form of coverage. And I think, again, Dr. Hoskins has been talking a whole lot about that, have a form plan which could, emulate a bit. We can have pan-Canadian plan. We can have 13, 14 different plans across the country that, as long as, like healthcare, there's some consistency there and the federal government's contributing. So I don't see any reason why we can't handle a national pharmacare program the same way as we're handling national health care. I'm not saying that this is my absolute proposal and that I feel we ought to trash private drug plans in order to do this, but I'm saying that this is in fact a viable option, and that the federal government then, especially in the beginning, in order to get it going, could actually provide some incentives. If they were smart, they would actually put some sweetener into it and get people to step up to it.
Sean, what do you think of that?
I think there's something to that. The one piece of the puzzle we can't forget, though, of course, is that since the creation of Medicare and the exclusion of drugs or pharmaceuticals from the Medicare model, we've had a separate regime evolve, this hybrid of public and private. And as I said earlier, the vast majority of Canadians are well served by the role of private insurers. And so it seems to me there's an opportunity to leverage the private model through, as I said earlier, direct tax support for people. I think we can go a long way in covering that cohort that's previously on the outside looking in by leveraging the private model as opposed to expanding public plans. But some provinces may choose to go about it a different way, and it seems to me the value of that is we'll be able to observe the experimentation. People here know the changes to OHIP Plus here in Ontario, and I'm excited to be able to observe how that model is serving is serving that population group here in the province of Ontario.
Okay, thank you. Nik, last word to you. You have nothing to add.
I have
You
nothing to add. I've already said it.
Nothing
Sorry.
to contribute to this conversation.
I only talk about things I know about, so I'm not saying anything else on this.
All right, with that, I want to thank everybody. Nik, Durhan, Sean, thank you very much. Great panel.
Thank you. Great panel, and I would like to invite Jason Field, President and CEO of Life Sciences Ontario, our sponsor today, to give the appreciation remarks.
Thank you, Kent. So last night I was sitting down at my desk and I was preparing these remarks, and my 9-year-old son came up beside me and he said, "Wow, cool, there's an Empire Club of Canada." And what ensued was a 20-minute conversation where I had to explain to him that this empire was in no way affiliated with Darth Vader. And no, your dad is not secretly a Jedi Knight fighting the forces of evil across the galaxy.
Aw.
But I do want to say thank you to the Empire Club for about 30 seconds making me the coolest dad in the universe. And of course, it's really important to host these sorts of events where we can have this type of very important policy dialogue on important political issues. So a special thank you to the Empire Club for doing such an outstanding job. On behalf of Life Sciences, I would like to express my gratitude to Nik for his unparalleled insight into the Canadian psyche, Durhan and Sean for sharing your experience and insightful perspectives, and Jane, of course, for helping to lead this discussion so well. Thank you all. In terms of closing remarks, I'd like us all to make this conversation more than just a one-lunch affair. These policies are moving forward as the federal government looks to implement national Pharmacare and to implement pharmaceutical pricing reform. I think it's important for us all to keep these conversations happening so that Ottawa is aware of how they will be felt on the ground here in Ontario and across Canada. As Canada's largest province and home to much of the country's life sciences sector, we support thousands of jobs in the knowledge-based economy, and clearly Ontario has a lot at stake. Based on what I've heard today, there are many concerns about how some of these initiatives coming from Ottawa might work in practice and may have the potential unintended consequences for patients, our healthcare system, and our economy. I think these are very serious concerns, and we need to consider whether these reforms are better addressed through, as was discussed, interprovincial collaboration. After all, it's the provinces and municipalities that are closest to the patients. They have succeeded in past in coming up with innovative ideas that can be scaled, spread, and supported by the federal government. Ultimately, Life Sciences Ontario is hoping that events like today will help shed some pragmatic light on issues that tend toward theoretical principles. These are major changes, and if they are to be contemplated, we need to ensure that they are the right ones for our citizens, for our innovative health system, and our economy. Thank you once again to our presenter, moderator, and panel, and I would like to say a special thank you to all of our members at LSO and the sponsors that support our very important work. And thank you, everyone, for coming out today. Thank you.
So, to close today, it's been a great day. Thank you so much for coming to listen to this important policy dialogue. We do have some important events left this season. Before New Year's, we would have had 16 events since September. Tomorrow we have Andrea Horvath. We have the Federal Minister of Environment, Catherine McKenna, the following week on December 6th to talk about, obviously, the number 3 most important topic, according to Nik Nanos. But it's quite a debate with our local provincial government on the best way forward in the environment. So there's a lot of interest in that event. And then following that, Ralph Goodale will be here on December 14th. Please join us for more events, and thank you so much. Meeting adjourned.
Thank you.
Well, that was fun.